So for our next talk, I call upon Dr. Deepa MG. She's Associate Professor at Government Medical College, Ernakulam. And as you know, this is a session on ophthalmology 360 degrees, so we'll be switching slightly sidewards on teaching aspects and as ophthalmology teachers.
Good morning. Thank you, KSOS Scientific Committee and Dr. Chitra and Dr. Satish for this opportunity. Well, my topic today may not be of much significance to all of you here, but if you are into the medical teaching or medical education arena, well, you have no escape from this. This is a drastic or revolutionary change introduced by the NMC in the recent times, that is competency-based medical education. And because of its increasing global acceptance, we somehow have to get used to it, and to understand what it is, let's go to the session. Well, at the end of the course, after 5.5 years, what the Indian Medical Council or the National Medical Commission aims to have as the outcome is an Indian medical graduate with requisite knowledge, skill, attitude to function effectively as a physician of first contact to the community, as well as to be one of global significance. Well, what is the CBME? This is an outcome-based approach in which the design, implementation and evaluation of the medical education program uses an organized framework of a set of competencies, and by competencies what we mean is the ability to do something successfully and efficiently in a real life situation. This discourages the conventional time-based training. It has greater accountability, flexibility and learner-centeredness. The assessment here is frequent and formative, and the feedback is inbuilt in this training program. So this table shows the difference between the traditional teaching method and CBME. The points are as already mentioned. Now, what is this difference between formative and summative assessment? In the earlier summative assessment, what we used to do was, after a set period of time, like maybe 1 year, we conduct an exam or a Viva OC and then assess the student according to the preset standard or benchmark. Whereas now in CBME, what we follow is a formative assessment in which the assessment is ongoing and continuous, and it is frequent, and there is an inbuilt mechanism for feedback. This feedback is applicable both to the teacher as well as the learner. The learner uses this to improve his learning, and the teacher uses it to improve his teaching. Now, what are the major components of CBME? First is competency, second is entrustable professional activity, and third is milestone. By competency, I already told that is the ability to perform something efficiently in a real life situation. So this actually defines knowledge, skill and attitude, which is already predetermined in the curriculum, considering the various factors in the environment that we are going to work eventually. So the competencies expected out of an Indian medical graduate by the end of the course is to be a clinician, to be a leader and member of the health system capable of analyzing and synthesizing relevant health data, to be a good communicator to the patient, family, colleagues and the community, to be a lifelong learner, and also to be a professional who is excellent in his subject, has ethics and is accountable to the patient, community as well as to the profession. Now, how this competency is designed? It considers both the cognitive, that is the learning part of how something is done, the affective part, that is the mental or the emotional side of it, and the psychomotor part of implementing any particular skill, and how the student acquires this proceeds through the different levels. As to first, he understands what is a task, what is a particular examination technique. Then somebody demonstrates it to the student as to how it is to be done. And the third step, under supervision, the student performs it, and finally he becomes confident enough to do it on their own. This is the Miller's pyramid. Now, the next important component is entrustable professional activity or EPA. Here what we do is we combine multiple competencies so that we bridge the gap between what we learn in theory and what we do in practice. For example, when we learn about a particular organ in anatomy, we have horizontal integration with biochemistry, physiology and all that, where they explain the physiological and biochemical aspects of that particular organ. And at the same time, in vertical integration, the clinical departments will come and explain to the students as to how the anatomical aspects that they have learned is helpful in coming to a diagnosis. So this horizontal and vertical integration gives them an idea in the beginning itself as to how we are implementing this theory in our clinical practice. Now the milestones in CBME, as the name mentions, it's very obvious from the name. Initially, the fresher comes as somebody who is fresh into the subject. Slowly, they learn to, they understand the subject as an advanced beginner. Then under supervision, they do the various skills and become competent. Later, they become proficient to do it without supervision. And in the final stage, they become an expert as to they can help others in doing the same skill. So this is the level 1, 2, 3, 4 and 5 of a student, and by level 5 the student is ready to assist other learners in performance of the particular competency or EPA. Now the gross change that has come up in CBME is in the teaching learning methods. I already told this is a learner-centered mechanism where the focus is given for the cognitive, psychomotor as well as affective learning domains, and the role of a teacher here has shifted to be a facilitator, to provide opportunities for the learner and give importance to self-directed learning. The gross, I am not mentioning all the methods, but the glaring change is that initially it used to be a teacher-centered or teacher-oriented method, where the main teaching method was a lecture class or a clinical discussion alone. But now the stress is on self-directed learning and small group learnings, where students are divided into small groups of 10 to 15 numbers, and they are encouraged to have discussions, brainstorming sessions, role plays, in which they go into the depth of the subject on their own, come to conclusions on their own, with the help of the teacher being the facilitator. Another important aspect that is being stressed in CBME is setting up simulation or skill transfer labs. Though theoretically we speak of these things, most of the teaching institutions don't have a simulation or a skill transfer lab. But stress is being given to implementation of this in all teaching institutions. Again, e-learning, that is utilizing information technology both in learning and teaching, is also given much importance, and newly they have introduced experimental teaching modules like electives, where the students are introduced into research and survey in the earlier stages of their medical education curriculum itself. Another very important aspect of CBME is the 8COM, which stress on attitude, ethics and communication. Earlier, we used to observe what our teachers used to do, how they used to communicate, and we used to learn on our own. No direct discussion or class was as such done for this. But this is given much importance in the present curriculum, and I feel this is very relevant in the present time of increasing violence against doctors, where communication becomes very important. So students are learning about the medico-legal aspects, about the rights of the patient, about how to be empathetic to the patient, how to maintain confidentiality, how to deal with bad news, etc. The assessment in CBME is also structured and also continuous and formative. Now the challenges that we are facing in the implementation of CME is basically the lack of sensitization and training among faculty, and the huge shift in the teaching learning methods, which is creating confusion among the teacher as well as the learner. Don't forget the huge logistics or the additional human resource and infrastructure that we need in proper implementation of this. Now the advantages is the outcome-oriented approach as well as accepting each learner as unique, and having more accountability in view of assessments in real-life scenarios. The disadvantages in going after these competencies and sub-competencies, most of the time we lose the essence of the subject and we lose our interest to go in deep into the subject. So, in my opinion, a hybrid approach incorporating the good aspects of the conventional teaching and later on shifting to CBME would be ideal in the current scenario. The only thing that does not change is change, and hence we also should try to assimilate this change. Thank you for your patient listening.
Thank you, Dr. Deepa. It must be something new to those of you who are not in medical colleges, but this is the new thing that all of us teachers in medical colleges are grappling with, and that's the way forward.